Afternoon, Val.
Hello. Not sure why I'm so dark. I'll try to figure it out. There we go. That's better.
Hi, Aaron.
I thought that was you. How are you? Good afternoon.
Good afternoon. I'll fix my name here. You know, I like to travel incognito, except everybody knows me. And I see Valerie is on. Hi, Val.
Hey, how are you?
Okay. And our erstwhile Tim Moore, who's always so helpful. Hi, Tim.
Good afternoon. This is Erin with the Department of Medicaid. It's not quite 2 o'clock and we're still clearing out the waiting room, so we'll give it just a moment before we get started.
How are we on our quorum? Um,
I
Erin?
currently, I have yourself, Val, Tara, and Misty logged in,
Yeah,
but the waiting room is still clearing up. As soon as we
Okay.
clear it, it fills right back up.
all right. And Steve is going to be late. He had to testify over in Frankfurt at 1. So he's going to try to get on as soon as his testimony is over.
Okay.
So we have a quorum
Yes, ma'am.
yeah, thank you.
And if you'll give me just a moment, we've about got the waiting room cleared. And Dr. Schuster TJ is coming in currently.
Oh, great.
And it looks like the waiting room is about clear if you want to give him just a moment to get joined.
Yes, thank you.
You're welcome.
Great. Always good to have a quorum so we can do business. We about there, Brent, Aaron?
Yes, ma'am. I was just unmuting to let you know everybody looks
Okay.
like they are logged in and on camera, ready to go.
All right, thank you so much. I appreciate it. So, if
I
you're
don't
on
think
this,
that's an ambulance. I think that's
if you're on this flight, this is the Behavioral Health Technical Advisory Committee meeting on July 10th, 2025. And welcome to you all. I believe we have voting members, Valerie Mudd. Can you just say here, Valerie?
Here.
And Tara Hyde.
here.
Great. And Misty Agnew.
Present.
Thank you. And TJ Littlefick.
Here.
Thank you so much. And Sheila Schuster. So Steve Shannon will be coming late. He has to testify in Frankfurt. And we have lost one of our voting members. I'm sorry to say, Mary Haas has had to resign because her husband is quite ill. And she needs to devote all of her time and energy to his care. So I know you will join me in thanking Mary for her service, not only on the BH TAC, but for years and years and years of wonderful advocacy for Kentuckians with acquired brain injuries. So we wish Mary the very best. Could I get a motion from one of the voting members for approval of the minutes that were distributed to you?
Motion.
Tara, okay, thank you. And a second, please.
Second, Valerie.
Val, okay. Any additions, omissions, corrections, anyone noted? If not, we'll have a vote to approve the minutes of our May 14th meeting. All in favor signify by saying aye.
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 I.
And opposed, like sign, and abstentions. Thank you very much. So the first thing on the agenda is that we just very recently got a response from Medicaid to the recommendation.
It depends on state.
I'm sorry, can people mute, please? So you may remember that we sent a recommendation to the MAC at their May meeting, asking DMS to issue guidance to the MCOs and to providers on the prior authorization process and forms to assure consistency across all MCOs. And DMS has sent us a response. The department developed documentation to outline each MCO's behavioral health prior authorization requirements to support providers in navigating the process, and gives a link to it. I think that I sent that out to most of you have seen that document, and it was a crosswalk across all the MCOs and their prior auths. It also notes additionally a national initiative led by AHIP is underway to streamline and improve prior authorization practices. DMS is actively monitoring this initiative and will share updates and guidance as new information becomes available. And then there is a link to I assume that that's the American Health Insurers something, AHIP. I'm sure that it's an organization of the national health insurers, and they have an issue brief. So we are going to have talk about prior auth right now, in fact, and there has been lots of discussion and lots of some bumps in the road. And so we want to hear about that. And I appreciate Commissioner Lee we sent Commissioner Lee some of the hiccups that we were experiencing. Steve Shannon and I did, and she has sent those on to the MCOs, and I think there are representatives from the MCOs here. So I guess we'll start with some of the things that we had brought to Commissioner Lee's attention. There were concerns noted, I think during the Aetna call, that CMHCs were unable to submit prior authorizations through their clearinghouse, which is Availity. And PAs were required to be faxed and then tracked that way. I wonder if somebody from Aetna is on and can respond to that, please.
Hello, Dr. Schuster. This is Kat Jones with Aetna.
Great. How are you, Kat?
I'm good. I'm good. So we did during our CMHC joint monthly meeting, we're made aware that there were some issues with Availity. And so that day we were able to get those several providers that were able to join us and some Availity representatives, and they did identify an issue that was isolated specifically to the CMHC provider type.
Oh,
And the place of service 53. For whatever reason, it was causing a problem, and that's what was generating that error message that several of the CMHC providers were getting. So as a result of that meeting, they were able to identify a fix, and that fix will be deployed on 7/18. So I understand that's still a week away, but providers are still able to submit via fax and via phone until that fix is implemented. So again, it was that specific provider type was causing something when that place of service 53 was being utilized.
was being utilized. Okay. Any questions from any of the providers that were affected by that? Steve's not on, but that was one that he had sent in. So if I understand what you're saying, Kat, they will still have to continue. The CMHCs are the only ones.
Correct.
Right, that
Correct.
have to submit their PAs via fax or phone until July 18th.
Yes. Yes, ma'am.
All right. Any other questions from anyone on that? Thank you. The other thing that came up was Passport by Melina, and it had to do with the dual eligibles. And as you all who are veterans of this meeting know, we have talked about dual eligibles, those that have both Medicaid and Medicare. It seems like forever. So that was one of the problems that had come up. And I know that one of the CMHCs also reached out to me and said that they were having that issue as well. So I think, David, you're on. I think I saw you, David Crowley.
Yes, Dr. Schuster, I'm on today for Passport. Yeah, we were made aware of that situation for the dual eligible members specifically on the Availity portal, to where the portal wasn't recognizing that bypass list that we've been working with for a few years now. So we're going to work with Availity to see if we can fix that issue to where the portal recognizes the bypass list, but for the time being, providers are just encouraged to submit those auth requests via other means, whether it be fax or phone, and we'll gladly process those as usual.
Okay. And will you let the providers know, David, when you've got that resolved?
Absolutely, yeah. I'll be in coordination with Steve Shannon on that as well, so we can make sure that they can still submit the request, of course, and we'll fax or phone.
All right. There were some other issues that came up that were passport issues. Denials for the CCS request, over 10, with reason being missing information, and the CMHC said that the information was provided.
Yes, and we've since resolved that issue. I got an email yesterday afternoon that the CCMHC worked with our utilization management department to make sure that information was provided, and that's been resolved. But if anything else comes up, I will. Steve has my contact information, and we worked through a few other aspects resolved to this, and I'll put my contact info in the chat today as well.
Yeah, because there was also a question about the targeted case management modifiers somehow not either being seen by the portal as being correct.
Right, and the portal is agnostic as far as modifiers go. So modifiers aren't required for the prior authorization request on the portal. They can just submit the T2023 auth request, and we'll accept that.
Okay. Do any of the providers on here have any questions about that? So you're saying, David, that is it only for TCM that the modifiers are not required?
For auth requests, the modifiers are not required for TCM specifically, but for the majority of the BRL services.
The modifiers are not required when you're going through the portal. Okay, and you had said that you would put your email address in the chat, please.
Yes, ma'am.
All right, thank you.
Uh-huh.
And who do we have on from WellCare, please?
Hi, this is Beth Santine from WellCare.
Great, thank you, Beth. The information I had from one of the CMHCs is that they changed the end date to the portal changes the end date to the end of the month, but when they submit it, it reverts back to 90 days. So they have to write their end date in the notes.
I'll have to take that back to our team with Availity to see what that problem is. I've not heard that one.
Okay.
So it's changing.
Yeah, it's apparently reverting it back to 90 days.
Okay. I'll take that. It's being worked. I will communicate when that gets resolved.
All right, thank you.
Which provider is that? So I'm sure we
That
communicate.
was 7 counties.
7 counties. Thank you.
Yeah, yeah. They did say that your utilization management director did hop on a call to walk through a couple of these things, and that it was very helpful.
Great.
So we appreciate that. And I think that's all I have. Does anybody else, any of the other providers on here have any questions? I should have asked that before with David on with WellCare.
This is Nina. I have
Yes.
some issues, a lot of issues from hospitals. And, they're variable between MCO. Globally, we're having a lot more peer-to-peers and delays in response on the decision of the peer-to-peer. We're having problems with faxing. 2 of the MCOs require fax instead of a live authorization, and they're losing faxes. We resend them. And again, significant delay. And one MCO said they have 5 days after receipt of a fax to respond. And typically the LOS, length of stay in a hospital, may not even be 5 days. So I guess in the interest of everybody else on the call, we've spoken to the Hospital Association, and Nancy Galvani is going to be arranging a meeting for all the members of the Psychiatric and Addictions Treatment Forum, which is, it's freestanding psychs and med surges with psych. And so Nancy's going to be helping to organize that with the help of the commissioner. And we are trying to schedule an in-person meeting with each MCO so that in one setting, they can hear from all the hospitals that want to be represented on issues pertinent to prior auth before we get too far down the road. So I know I saw Commissioner Lee on here. That's going to be something that we'd really appreciate DMS participation, but we thought it might be more efficient rather than me going through every MCO and every hospital and everything else to approach that in a global way, pull all the hospital issues together, and then meet in person independently with each MCO with DMS presence. So it's a lot of stuff.
And
And we want to make sure we get off on the right foot, or we're early into it, we're having problems. So anything we can resolve now will certainly benefit the patient on a go forward basis.
yeah, I think that's why I was glad that the timing of the BH TAC was early on in this process, because I
Yes.
think we all knew that there were going to be issues.
Yes.
Because we haven't had prior auth for a long time, and we've got new staff, both on the provider side and probably on the MCO side. I'm a little bit
Yes.
confused. Let me just clarify with you. Are you having a meeting with all of the MCOs and all of the hospitals together? Or are you
Yes.
having?
No,
Okay.
we'll have the MCOs separately. So we'll have all the providers.
Each one
Yeah.
separately. Okay.
Yeah, we'll head at the hospital association. And it's kind of like back in the old days. Commissioner and others may remember how we used to have in-person meetings. And so we'll invite all the representatives for the hospital, anyone who has BH services. And then we'll schedule on a, back-to-back basis, the MCOs to come in person into the room with representatives. And we'll ask for DMS to be there as well. So that's how we're going to handle it. We thought that might be most efficient because we've brought up issues like on the hospital DMS MCO meetings in the past couple of weeks. And we just want to approach it comprehensively and in a collaborative way with all the MCO partners and DMS partners as well.
Okay.
So that's what it'll be. And I'll let you know, Sheila, when that's
Yeah.
scheduled so that you
Yeah,
can
let me know if
keep
you
track
will.
of what's going on.
Yeah,
Yeah.
just trying to provide a forum for these things to get worked out.
Thank you very much.
Yeah, and we're, obviously the important thing is that people who need the services not be denied those services unless there is really a good reason why it's not appropriate. And
Right.
we don't want paperwork kinds of.
No, we don't. And we also want to make sure that the provider gets paid for providing the care to the patient that's needed. So I'll
Right.
keep you posted. Thank you.
All right, thank you. So that's going to be the hospital. Let me go back to Aetna and Kat, if you're on. One of the CMHC said we were supposed to be able to start submitting requests earlier than the June 25th go live, but because they're ProPat that houses what requires auth, said auths weren't required until 6/25, and we were unable to submit until 6/25.
Sure, I can address that. So
Okay.
definitely, our intent was to allow providers to submit for PA, earlier than the actual go live date, so they would be able to stagger requests and alleviate the burden of having to submit all of those requests on 6/25. So our PA requirement lookup tool, which is what that ProPat is, and our availability portal are linked together. And we did not realize that this would be an issue if a provider attempted to submit a PA request via availability prior to that go live date of 6/25. So what would happen, like for example, we allowed submissions to begin on 6/9. And so when they tried to do that, they were getting a message through availability saying PA is not required because that go live date was 6/25. So as soon as we became aware of this, we addressed it in our virtual office hours and directly with specific providers that had outreached us. That is one detail we did not guess that was going to be a problem in our attempt to let them submit early. So providers were still able to submit PA requests early via phone and fax prior to that actual go live date of 6/25.
Okay, so that was your efforts to try to ease things for providers, and it ended up that there was a glitch at your end.
It did.
Portal. Okay. This one says Aetna requires the OTR along with clinical information from the chart. that was not clear at Go Live that the OTR was required and not optional.
Okay, so we did include links to the PA forms on our provider notice that we sent out on 5/23, and we have reviewed that in our ongoing virtual office hours with providers, and we very much apologize if it wasn't clear. However, without the basic information that is on those forms, for example, what service code is being provided or the number of units of that service that's being requested, we really can't build an authorization. So if we just get a clinical chart, the team that is, we call it shelling, constructing, building that authorization doesn't know what to plug in for the service code or how many units without that form.
Okay, so the long and short of it is that the OTR is required.
Yes, yes.
Okay, and it's not optional. And you've cleared that up with the providers as these things, as the questions have come up?
Yes.
Yeah, okay. Aetna's requiring us to provide the TRIS ID for both the case manager and their case manager supervisor, although that is not listed on the OTR.
Yes, that's not listed on the OTR as, the providers may submit either the DMS universal form or the behavioral health prior authorization form, which is a standard Aetna form. And the reason why that we have suggested that providers include that is when we are processing targeted case management requests, and we have noted that there are occurrences where there may be multiple individuals with the exact same name in the DBH DID TRIS system. And so, or that their TRIS account might have been under a different name than what is noted in the medical record as the provider of targeted case management. So we suggested that providers add that ID information in the request to avoid those situations where we may get multiple results when we're checking for compliance in that system. And so we've continued to educate providers of that. And we also received, let's see, it was yesterday, approval for a provider notice. DMS approved it, and that did go out yesterday as well to all providers and posted on our website, that serves to educate providers about the TRIS system and how and why we access it and utilize it.
Okay, and that provider notice went out, what'd you say, yesterday, and is also
Yes.
on your website? Okay.
Correct. Mm-hmm.
All right, thank you. The next is that your portal does not have the correct modifiers for TCM.
I think this was the same that David was speaking about. It's not that we request the modifiers. We have advised providers to either enter it in the notes section of availability or put that in the notes section if it's on the PA forms for the fax forms, without knowing what type. Those modifiers tell us what type of TCM is being requested. Without that information, we don't know what specific criteria should be utilized for any determinations. We definitely understand that it takes some time to get availability changes in place. It could take several months. So in the kind of an interim fix, we've asked providers to jot that in either in the availability note, or if it's on a fax, in the notes section on those forms. Otherwise, we don't know what specific, which one of the regulations, the criteria sets to apply.
So are the modifiers not needed?
If they indicate the type of TCM, that either is, for example, if it's for individuals with a substance use disorder, they can spell that out. We've said, or you can put the HF modifier. If it's for those co-occurring complex individuals, they could put TG or spell that out. They just need to let us know what type they're requesting.
Okay. And was your portal down? Was it down for a while? I mean, the note here is the portal was broken.
That was what I was speaking to earlier. That was just for the CMHC specific issue. Yeah,
right.
that's what that was.
Yeah,
about.
unfortunately, it's a high volume provider.
Yes, but we've got that fix that's coming, and that will be in place soon on 7/18.
July 17th, okay, or July 18th.
18th, yes.
Yeah. So we were told that if the authorization numbers are not on claims, they will deny, and they could not turn it off until it's resolved.
So that is in regards, so operationally, the turning off or turning on of prior authorization, you know, in all the related systems is a large undertaking. So turning off, you know, back off in all of our related systems is just not a feasible resolution. So we've attempted to, you know, actively address these issues in our virtual office hours that occur weekly and with, you know, individually, but to engage in a operation that would effectively, you know, turn PA back off. That would likely take longer than it would to resolve the individual issues. It's a significant undertaking to turn it all back off in all the
Off and
systems.
on. Okay. And the final is Aetna says they have 24 hours to render decisions for all SUD, even when SUD is secondary diagnosis, which means if we submit something through the portal on Friday and they call after hours, they will render a decision without the clinical consult needed. Usually it's a denial.
Okay, so our Medicaid actual contract defines our turnaround time requirements for non-urgent and urgent requests. So per our contract, SUD treatment services and requests have to be processed as urgent, which means we have a required 24-hour turnaround time in order for us to be contractually compliant. We do, however, allow providers to submit requests within 1 business day of admission. So if we were to take that example and say, okay, a recipient has entered into substance use residential on Friday. Providers have until to submit that prior authorization on you know, they come in late on Friday evening. They can submit for prior auth on Monday, and that decision turnaround time would be Tuesday. But in order to be compliant with our contract, if we get a request for a substance use treatment service, we have to decision that within 24 hours. That's a contractual requirement.
So the concern for the provider is if they wait until Monday and they go on and provide the service, it's possible that that service is not going to get paid for, right?
That is a valid concern, but
Yeah.
if they submit it on Friday, we have to make that decision by Saturday. So if we can't get clinical by Saturday, then we have to make a decision by within that 24-hour time frame. Does that make sense?
Well, it makes sense if that's the requirement. I guess I'm going to
Yes.
ask the DMS staff, is that is that a DMS requirement? Obviously, it's in your contract. I'm just trying to figure out if there's something that could be done to address that, because there's valid issues on both sides.
Hi, Dr.
Oh,
Schuster. It's
Commissioner Lee
Angela.
or Veronica, Angela?
Yes.
Somebody?
So I believe again that requirement is actually based on statute around emergency. I'd have to pull it up. It's been a while, so I can't cite the exact for you right now, but we'll pull it up. But I believe again, we'll take it back and look, but I think it's around actually based on a statute requirement.
Yeah, this is
Angela, this is Nina. I guess that, you know, there'd be an issue for the hospitals too. So my understanding that, let's say a patient comes in on Friday night, and so the prior auth isn't submitted until Monday. If the prior auth is approved within 24 hours, let's say on Tuesday, it's not going to be retro back to the date of admission? Only to the date of prior auth?
No, it definitely would be retroactive to the date of admission for sure.
Okay, thank you.
My concern, that's a good question. My concern was that if it's denied,
It was right.
then you have, hi, Steve, then you've provided that service for 3 days or 4 days. If they come in on Friday evening and you have that overnight Saturday, Sunday, and Monday, because you're not getting an answer until Tuesday.
And so let's play that out. Let's say it gets denied and the provider requests a peer-to-peer. How long do you have to respond to the peer-to-peer in contract?
I believe
Anybody?
that I believe, Nina, that we have 48 hours, but I want to note that I want to firm that up and give,
Okay.
and double check that for sure.
Okay, perfect. Because then we could be exposed to 5 or 6 days of care and ultimately still be denied. So thank you.
So can we put a pin in this or put it in the parking lot or whatever that expression is? Let's not lose track of this. Because if it's in statute, then we need to look at that and try to figure out if, what the intention was. And I'm sure it made sense in terms of emergency or urgent services. But I'm trying to see if there's something that can, if it's not in statute, if it's in reg, is there something that can be looked at? So Angela or somebody from DMS, I think, Veronica, I saw you on. Can somebody follow up on this for us?
Yeah, absolutely. I was going to say, I think it would be very helpful because we follow federal and state requirements that are in statute and law and regulation about what our timeframes are. We did not make them up. We follow the law and the regulations.
Right.
So perhaps what would be best for us to do is at the next meeting is put that, it would do a little presentation on it. So everybody understands what the requirements are. I totally understand there because there's I think what probably isn't specifically addressed, though we'd have to go back and look, is things like somebody comes in and then within 3 days you're submitting those other kind of policies that you're submitting a prior authorization within 3 days of admission and those things. So we'll do our best to try to create a presentation that sort of covers all those scenarios.
That would be very helpful. Thank you. I'm going to make a note to put it on our items for our 9/11. That seems unlucky. And that's the date of our next TAC meeting. But so kind of a time frame. In other words, what's in stone and what's fixable or changeable. Thank you. That's a good discussion. And thank you for weighing in, Nina, from the hospital point of view. Next on my list is Optum United. We cannot see, this is an issue. Yeah, they couldn't see any of the auths that were preloaded. And I think, I don't know if Krista's on or Leah, I was told that it was only 2 providers that had that problem. I think one was 7 counties, and I've lost the name of the other, Commonwealth Health. And nobody else had that problem. So I find that you all are looking into what the issue was for those. And did you want to ask also about whether any other providers were having that issue?
Hi, Sheila. It's Leah Vossen. I'm here for Stephanie Koenig today. And we did identify one additional provider group with Bluegrass that is having difficulty seeing their authorizations on the portal. We have put a workaround in place where our provider relations staff do have access to that information to be able to provide it manually to those providers while we're working on the technology fix. And they're doing root cause analysis right now to determine why. It's just those few provider groups that are not seeing their authorization responses on the portal so that we can get it fixed.
Oh, okay, great. And if there are any other providers, I'm assuming by this time you would have heard from them. Would you guess, Leah?
I do think that we would have heard from them by now, yes.
So right now it's just those 3 providers that were having that particular. They also said that your utilization management department is the one MCO that we don't have a personal contact for.
We have provider relations advocates assigned to each of the provider groups that are addressing internally with different departments, depending on what the services are that are under review.
So they should use their provider rep for
Yes.
any of these issues?
Yes, and we do have the standing meeting on Thursday afternoon that providers can come into, where we have provider relations and both on, in order to address any inquiries or issues in that meeting as well.
Right. I think I got a memo to that effect. So you're essentially having an office hour at 3 p.m., I think Eastern time, where you're available for providers to come in and have discussions about any of their issues.
Correct.
Okay. And that's 3 o'clock Eastern time every Thursday.
Yes, but
All
they
right.
don't have to, they don't have to hold on to them if they're pressing. They can
Right.
also contact their provider relations advocate in the interim.
Okay. All right. Thank you very much. And then Humana. We have somebody on from Humana.
Yep. Hi, folks. It's Liz Stearman from
Hi, Liz.
Humana. Hi, Dr. Schuster.
Thank you for being on. So this was Humana changed their start date at the last minute, which changed their date we could start entering. We had been entering on June 17th, which was the original date. Then they called us and told us to stop, but honored everything that we had already put in the system, which we appreciated. So I guess that was just a change. Was it a change in your start dates?
Yeah, yeah, there was some confusion originally, the ASAM fourth edition criteria. The first notification of that was going to start on 7/1. And so we made the decision to start our prior authorization requirements at the same time because we didn't want folks to have to use one set of criteria for like 5 days and then switch to another one. So we went ahead and moved our start date to 7/1 for everything. But then the state did come back out and switched. The ASAM fourth edition could start on 6/25. So we didn't want to switch again. So we just sort of stuck with it. There was just a lot of moving and shaking there while everybody was trying to align everything. So we absolutely did honor everything that had been submitted prior to that. And we still had quite a few early submissions that we were able to get through.
Thank you very much. The other,
Yeah.
there was an issue in the portal for uploading clinical documents with the authorization. They had to go out with the claim. Apparently they gave you some feedback about that. That was 7 counties and you all corrected that issue.
Yeah,
So,
we've got a fix in place. It's not corrected yet, but yeah, it's coming shortly and we have a workaround.
being
Yep.
fixed, right?
Yep.
Okay. Still having issues with submitting requests for Medicaid only services when they have dual coverage. Here we are back with the dual coverage.
I know. It's the exact same
no off
issue.
because of another payer. You know, it's the same thing that we. So are you trying to use the what do we call
bypass?
it? The bypass.
Yeah.
Bypass list, Sheila, Medicare bypass list.
Yeah.
I'll be honest, I was kind of hoping you would call on us after Melina because I feel like I could have just used all of David Crowley's responses and just, saved us some time. But you're right. Yeah, we did get on to our CARP call and made some announcements to say it is the same issue. Our system was not really ready to be able to accept those for dual members. And so we have communicated with our providers and anybody who's on here, at this point in time for our duals members, we are not going to be requiring that auth to be put into place in order to pay claims. However, if providers would still like to pursue authorization, just because I don't blame you if you just want to be doubly sure, it just has to be done via fax or don't mail it, fax or phone. So our other opportunities, it's the system. It's a very similar issue. So we will not be requiring auth for those for the first 2 months. And when that changes, we would let everybody know while we're resolving that. So.
Okay, so that's very similar to what Passport by Melina was telling us, David was telling us. Okay.
Yes.
Just
Just ditto that.
And we have that same issue. And of course, Steve and I feel like we spent our lives dealing with the dual eligible issue.
I know.
So the last one is the portal is missing TCM modifiers. And they notified us that the fix was requested, but would be sometime in July.
Similar to Melina, we do not require the modifier to be entered at the point of authorization. The modifier does have to be on the claim. That's what helps pricing. But we're really just authorizing targeted case management as a service. More generally, we will have the opportunity to add the modifier in the future, but it is not required for claims payment.
Okay. Thank you. I think that's all I had. I'm just looking at the chat to see if there's anybody I missed.
Isaiah House and Key Assets had
Yeah.
some comments in the chat, Sheila.
Yeah, I see that. Zachary Cornett from Key Assets has found that modifiers are mandatory for Aetna with TCM PAs, even though they are not a required field in availability. This has resulted in many cancellations of PAs for our organization.
Again, it's,
Remind me-
oh, I'm sorry, Dr.
I
Schuster.
was going to say, remind me, Kat, what you said.
Sure. Yes, it's not because again, those modifiers aren't in availability. They can put in the note what modifier, or they can indicate what type of TCM is being requested, because without knowing that, we don't know which criteria is applicable. So it's not that they have to put in the modifier in the modifier space. They can say, okay, it's HF and we know it's for substance use, or they can say in the note, targeted case management for individuals with a substance use disorder. So either they just have to let us know what type of TCM is being requested.
Okay. And this is Optum United. Isaiah House is also having trouble seeing the PA information. So you can add them to your list of now 4, I guess.
Do that. Thank you.
Taylor Toll. We've been working with utilization management to try, but still unable even after supplying the original submission document from Provider Express. So who do they need to be talking to, I guess, Leah?
So Michelle or Lucy with you on, which provider relations advocates working with us, Isaiah House?
It's Lucy. We can touch base with her. Thank you all.
Okay, great.
That would be Lucy Howard.
Lucy Howard, okay. And Kat, you have something in here about peer-to-peer. The request for peer-to-peer review must be received within 2 business days of the issuance of the denial.
Yes. So for example, if an inpatient stay was denied today, they would have 2 business days in order to request that peer-to-peer occur. And then I see in the chat that someone indicated they thought it was 5 days. So I'm going to follow up again, just to triple check and make sure that I'm communicating the correct information.
Yeah, and then somebody's saying we scheduled a peer-to-peer last week and we're told the next available time was in 7 days, creating a longer delay. Is this a standard time frame? So obviously we're back to kind of looking. That's good. Maybe Veronica, when you all prepare something for the September meeting, we could look specifically at the, after a denial, the peer-to-peer kind of timeline.
Yep, I've noted that, Dr. Schuster.
Okay, thank you very much. And there was another question in here that I didn't know the answer to. Can someone guide me on how to get pre-authorization for T 2023 or H0015 with regular Medicaid? Do you have to have prior auth with regular Medicaid?
I'm not sure, Dr. Schuster. I'm not sure if those require prior authorization or not, but I did put the CareWise telephone number in there for
Okay.
contact information.
yeah,
So
I see
we
that.
can double check and see if those actually do require prior authorization, but I do not know right off the top of my head, and I'm not sure if anyone in the Medicaid, any employee with Medicaid knows that off the top of their head right now.
Well,
This
I
is
always
Angela
assume you all
Sparrow
have
for,
unlimited capacity, Commissioner, to know all this stuff off
for
the top of your head, but I'm
fee
sorry.
for service, there are no prior authorization requirements on the behavioral health services.
Thank you,
Ah.
Angela. There you go.
You're welcome.
There you go. So Rhonda, you don't have to get prior auth for those things.
But if there you are delivering any service outside of behavioral health, you know, there's a telephone number if you have any. But if you have any billing questions or you have claims that are denied, you can still reach out to CareWise regarding any issues related to billing for straight Medicaid.
Great, thank you so much. All right. Any other issues that have not been talked about? This has been extremely helpful. We very much appreciate all of the MCOs being on, and appreciate you, Commissioner Lee, sending out some of these things ahead of time. I think that was very helpful. Anybody else going once, going twice?
Dr. Schuster,
Yeah.
here, I would just add that one of the common questions that we have had is when they're using Availi, there's been some confusion on where to list what service you're requesting. So I just kind of wanted to promote that
Oh, okay.
the service type is the first question you're going to get. And I think people are looking for behavioral health, but what's listed is mental health. And if you select mental health first, you know, that service type, then all the levels of service will populate correctly for you to correct what level of care you're asking.
So is that true if the service is for substance use disorder?
Correct. Everything is listed under mental health instead of
Okay, that's the confusion. So they're looking for behavioral health and they're looking separately, right?
I can put a screenshot in the chat if you're okay with that.
Yeah, that would be fine. Thank you. Appreciate that.
Thank you for the promo opportunity.
Yeah. All
Dr.
right.
Schuster, this is
Yes.
Erin. The commissioner can only be with us till 3 o'clock, and we're getting a little close to that. So I didn't know if there was anything she wanted to address before having to drop.
Yeah, thank you very much. I was just going to ask her if there was anything either on the agenda or otherwise that we'd always love to hear from her. So, Commissioner?
Thank you. I think I joined mainly for item number 6, the update on the phase 1 of the multi-state rate study. I just want to make sure that we're being responsive and that we understand what the ask is here. I know we created a phase 1 study that contained a multi-rate study and compared rates across Kentucky Medicaid across other states, and there was a request to refresh that. And then there was a request for a phase 2 study. And so, and looking at the phase 2 study questions, they seem to be pretty detailed and pretty in depth. You know, for example, you know, are rates a barrier to achieving access? Do rates support a diverse workforce across all 20 counties? And so it looks like the analysis for that phase 2 may be a little bit more in depth than what DMS has at this time as far as internal capacity and specialized expertise to conduct that in-depth study. So I, again, just want to make sure that we're being responsive and that anything that we can provide, any data that we have in our system, we can provide that, and to see exactly, you know, what the ask is for phase 1 and going forward, what we need to, what we should be considering.
Yeah, thank you very much, Commissioner. I think that there were some follow-up questions. Is Bart Baldwin on?
I'm here, Dr. Schuster.
Yeah,
Yes.
do you remember that you had some follow-up questions around ABA providers for one thing? And we
Yeah,
had also asked about, I think they realized, Commissioner Victoria told us that she hadn't realized that what Illinois and Missouri should have been included as contiguous states for comparison purposes. And I thought that was also going to be the wrap up of phase one.
Yeah,
Yeah.
so there was, as far as the ABO, it says, ABA is one, primary ABA codes 97153 and 155.
Yep.
So, yeah, and I've got a note here that, that this is going to require some more research. So is the request to do a refresh of one? And then I think on the phase two, I don't think that we'll be able to do that phase two piece, but so the request on this is just an update on, based on those questions that you all submitted.
Yeah, I think that we heard back either directly or indirectly from Victoria that phase two is probably not going to be possible or not going to be possible for some time. There also was kind of the, is this being done over at the LRC and their data analytics and so forth? There's been lots of kind of unknown questions about what they were doing. But the original story was that they were going to be looking at rates over there. And so we had gone, I think, and Bart, correct me if I'm just misremembering, but I thought we had asked first just that phase one be completed. And we saw that with the contiguous states and then the ABA codes.
Okay.
Yeah, the other additional piece on the refresh of the phase, kind of finalization of the phase one, was in some instances the rates were incorrect from other states, and in some instances it used the comparison. For example, I'm trying to, like the H2015, which is a bachelor's level requirement, was comparing that to a licensed person in another state. So I think what it was is some of the comparisons didn't use the primary level of clinician that generally bills for that code. So that was just more of a cleanup to go in there and make sure it matches an apples to apples comparison, because on most of the codes, there's either a clinician, licensed person, or a associate that's the primary deliverer of that code. So there was just cleanup things, in terms of beyond ABA, but even in just the other general outpatient mental health services as well.
Okay,
But
we'll go back and look at those
we-
questions that you've posed.
Yeah.
On
We had
phase
that-
one.
Yeah,
we had that
we
in
had
the
kind of put
lines.
phase two in abeyance. I think we had heard that from Victoria.
Yeah, so we'll go back and take a quick look, and just knowing that sometimes it is really difficult to compare rates across states when, because of the different components and, for example, we've been talking about prior authorizations, what's prior authorized, who's delivering the services. If we cover more than another state in a surrounding county or surrounding in a contiguous state, do they cover, all those services? So let us go back and take another look at that, and we'll respond to those questions that you have. I think I've seen the questions from the phase one and some of the conversations that, so let us go back and take a look at that again. We want to be responsive, make sure that we're giving you exactly what you're requesting. And I guess, Dr. Schuster, to your point on the, LRC was supposed to be doing some rate studies. I haven't seen any of that. I don't know, what has happened there, but if they are, we definitely don't want to duplicate efforts if they're doing something. So
Yeah,
we'll take,
I think it kind of came at about that time that they had hired Stephanie Bates and, had this Office of Data Analytics. And so we kind of backed off on the phase two. But, it's a good question for the MOAB maybe to ask, because rates are going to come up, I think.
Yeah.
Anything else, Commissioner Lee, that you want to comment on?
I just think, I'm sure that this entire group knows that the House Resolution 1 is what we're, referring to as the federal legislation that passed last week. We are still continuing to work with national partners and CMS as we move forward and look and evaluate dates on things that we need to implement related to that new legislation and how it impacts our program. We are still, our primary focus and mission is to make sure that every individual that is enrolled in the program and the Kentucky Medicaid program receives access to the care that they need. And so we will be continuing to evaluate that legislation. We continue to receive lots of questions on the impact. We believe that there's still a little bit of information or guidance that we're going to need from CMS, specifically as it relates to work requirements, cost sharing, those sorts of things. So just wanted you to know that we continue to evaluate and work with our national partners to make sure that we are moving forward in a way that it ensures that the Medicaid program remains viable for future generations.
Yeah, thank you. You all released, I think, Steve Bechtel's work when we were all kind of, is it going to be caps? Is it going to be block grants? Is it going to be a change in the FMAP? And released a really, really helpful piece where he went through and kind of tried to imagine, what the impact was going to be. Do you see at some point you all being able to release something like that now that we know what the pieces are?
Yeah, I think, we're going to continue to evaluate, see how we move forward. It's definitely something that, we have some concerns about related to the impact of the program and as we move forward. But as we do have more information, we will share it as it becomes available, particularly as CMS issues additional guidance. There are some aggressive timelines in the legislation, so we are pulling all of that together to see specifically how it may impact us. But if you looked at the legislation, you see that some of the provisions have a due date in 2028. However, we will have to be laying that groundwork for anything in the future. So we're just keeping our eye on any activity at the national level related to anything that might impact that legislation and how we move forward with implementation.
Yeah, I appreciate that. Appreciate your being on, Commissioner. Aaron, thank you for reminding us that we were going to lose the commissioner here shortly. But thank you for asking about the multi-rate study and multi-state rate study. And we'll look forward if Victoria or somebody is ready to report that in our September meeting, that would be fine. Otherwise, we could look toward November for doing that.
And just thank you all. Thank everybody on the TAC for everything that you continue to do and for being there for our Medicaid members. We really appreciate it. And thank you all so much. And I'll see you at the next one.
All right. Thank you. Bye-bye. The next is the report of the study. This is revised on the behavioral health needs assessment. And I assume that it's going to be some of the Myers and Stauffer staff. I don't know who exactly is going to be reporting that.
Yes, it will be
is
me,
that you?
Martin McNamara. Hi,
Okay.
everyone. Yeah, share my screen.
Okay, thank you. And we did send it out, Martin, a few days before the BHTAC meeting, so people had a chance to look at it.
Okay,
Appreciate
great.
you working with us to answer some of our questions and put it in really good shape.
Okay. So just to start things off, these are the CMHC regions, and we'll be looking at these just as a way of geographically categorizing things. Not everything in this presentation is the responsibility of the CMHCs. These are just a convenient region to reference when it comes to behavioral health. Now, the first measure that we're looking at here is a safety net score. This is developed based on population density, poverty, Medicaid coverage, and communication in English. Higher scores are going to be darker, the brown on this map, and those represent more risk due to these factors. That will be more difficulty accessing care due to like the geographic constraints, poverty, or communication. You can see on this map that the highest scores are found in regions 11, 12, 13, and 14 in the southeastern portion of the state. Now, looking at another measure, this is overdose deaths per 1,000 population. And again, here, the darker sections are going to be those that have more overdose deaths per capita. And those are occurring in the eastern regions primarily, including regions 9 through 15. So really the eastern and southeastern regions of the state are those that we're seeing the most needs in terms of substance abuse, and then also concerns about difficulty accessing care. So we're going to be referencing regions in a few more measures. Now we're going to take a look at Medicaid utilization. This is looking at behavioral health provider types. This information is for distinct claims for state fiscal year 2023. Only these billing provider types are included. So it's only billing provider types that are specific to behavioral health. You can see that BHSOs in light blue provide the most procedures, followed by behavioral health multi-specialty groups in orange. Some other large provider types are the CCBHCs in dark brown and then the CMHCs in dark blue. We're also going to look at this regionally to give us an idea of how different providers are meeting behavioral health needs in Kentucky in different regions. So now you can see that certain providers are going to be much more common in some regions than others. A few things to note. In some regions, you have the CCBHCs, specifically 6, 7, 9, 10, and then 15. And you'll see a little bit of those outside the regions. And the reason for that is this is based on the recipient's region rather than location of the provider. So you'll see even where regions where there is not a CCBHC, there's still some services provided them because it's based on the participants, the patient's region. Some other things to note. The BHSOs meet quite a bit of needs. Those are going to be the light blue at the bottom of each of these bars. They meet quite a bit of needs in every region, but they are more predominant in some. You'll also note that licensed clinical social workers are much more common in Region 1 than the other regions. And then also that the behavioral health multi-specialty groups in orange are going to be much more common in some regions than others. There are some factors behind this, but really the point here is just that different regions are meeting behavioral health needs with different provider types. And in some cases, this might be cases where it would be helpful to have a provider come into that region or more predominant in that region. But in others, you can see that they're just substituting different provider types depending on what's available in the region. Now, next, looking again at the same set of data, just by services rather than the provider. These are categorized based on the procedure codes and only those billing provider types that we saw listed earlier are included. You can see that psychotherapy in orange is the largest service provided. And then evaluation and management, peer services, and other outpatient services are also quite significant. On the next slide, we're going to look at this again by region. So here you can see that there is quite a bit of variation between the regions. A few highlights for this. For one, the adaptive behavior treatment service is available in several regions, including 4, or rather it's performed in several regions. This doesn't necessarily speak to the availability, but that's in 4, 6, 7, and then a little bit in other regions like 11 and 14 and 15. So this doesn't necessarily get to whether that service is needed, but it might suggest that there might be an unmet need for that service in some of those regions that don't have that available, or don't have that performed, rather. Another note that the outpatient SUD services are offered most in region 7 and a little bit less in most of the other regions. And then residential SUD services are available throughout, just to varying degrees. That's going to be the dark blue at the top here. And then also SUD assessments and screening are in the lime green here, and are available to, or are performed to some degree in each region. One note is that the regions that we saw had the highest the highest overdose deaths in the map on the earlier slides. That was the 13, 14, and 15. They don't necessarily have the highest or the highest SUD services, so there might be some unmet need there, and those SUD services being mainly the dark blue at the top, the orange, and the lime green. Now, another way that we looked at this was for who is actually performing the service. This is based on the modifier code on the claim. Some claims don't report a modifier that would indicate who performed the service, and those have been excluded from this. But you can see that the most common is a licensed counselor, therapist, or behavior analyst. And some of these are grouped together because the modifiers don't always distinguish between each individual specific type. Licensed associates are also quite common, and those are in the brown at the bottom. On the next slide, we'll look at this again by region. So here you can see there is quite a difference between the regions in who is performing the different services. So a few notes here. This dark green is going to be a doctor of medicine. Second from the top in each of these below the peach color. And those are most common in region 7 and quite a bit less common in the other regions. And again, this is just based on the modifier and only specifically for those behavioral health provider types. This orange color towards the upper half of each of the graphs is peer support, and you can see that that is most common in region 5. Then you'll see that licensed clinical social workers in blue towards the bottom half here of each of these, they are most common in region 1, and that matches what we saw before with the provider types as well. So you can see that different regions are meeting the needs of the behavioral health needs in those their region differently. Some of this is going to be because of just provider availability. If, for example, there's more licensed clinical social workers available in Region 1, they're going to be performing more of the services. And then in Region 5, you see that they're meeting more needs with peer support groups than other regions are. And this isn't to say that any specific provider type is the right one for any given need, but the providers performing the services are different between the regions. And if there are unmet needs, it may be because a specific type of provider is unavailable. Okay. Now, we also looked at provider locations. And you can see that the most populous regions of the state have the most behavioral health providers. Here, the CMHC locations are going to be in red, and the non-CMHC locations are going to be in blue. You can see that there are quite a bit of CMHC locations, and there are a lot of overlapping dots here. So you won't be able to tell exactly which providers are which, but you can tell that there's like quite a few in Louisville and Lexington. And then you'll also want to note that the Central Eastern region has disproportionately high rates of deaths due to overdose, like we saw on the earlier map, but there's also relatively few providers here. And there's going to be a greater distance to travel to those providers. Then in the Western counties, we saw higher rates of suicide and self-inflicted injury deaths. We didn't include that map, but that is something that we noted in our analysis. And there's also relatively few providers out here, and there's going to be a greater distance to travel to those. Then also counties with lower safety net scores in the Northwest Central region. We also see fewer providers there. And part of that's going to be related to the same factors as the safety net scores, because it is a lower population density region. Now, looking at CMHC specifically, we had included some CMHC numbers in our previous presentation, but we wanted to provide an update on those. This is based on 2022 SAMHSA data, and it's supplemented with location data from CMHC websites. So we should have a better idea of exactly how many physical locations there are. And one thing to note is that this only includes physical locations inside of the currently recognized CMHC regional service areas. So some of the CMHCs have other locations throughout the state, but because we just wanted to count the specific regions, only those in that their currently recognized region are included here. And with this, it's not necessarily the case that the locations per 1,000 members, which is intended to get to a more per capita number, lower or higher isn't necessarily better. In some of these regions, there are much more other providers available, or they're just more centralized, in which case a single CMHC location can meet more needs. So this isn't necessarily to say that any specific number is bad or good, but just that these are the locations that exist for those CMHCs. And this is the last slide that I had to present. So I'm going to pause there and see if there are any questions.
Martin, on slide 10.
Sure.
I don't remember that we talked about this. It just caught my attention. There's the second one listed as Doctor of Medicine.
Mm-hmm.
And then two down from that is psychiatrist. And I'm trying to figure out who the doctors of medicine are if they're not psychiatrists.
Mm-hmm. Yeah, we only have the modifier information, which is a bit limited. So those in the modifier type are just listed as Doctor of Medicine. So it does not specify any specialty beyond that.
So we really don't know if the doctor of medicine might really have been a psychiatrist and it was just coded differently or wrong, or
I
right?
think that's possible.
I'm just trying to think what the role would be in behavioral health for a doctor of medicine. I mean, I guess you.
Maybe primary care.
Yeah.
And they bill a behavioral health service at that point.
Would it be billed as behavioral health?
They might do a med management, maybe.
Yes, I was just gonna say, there are plenty of services that, primary care physicians can deliver that are considered behavioral health without having to have the psychiatric specialty. They can do SUD treatment, and so, I think that's probably what's showing up there.
Yeah, that makes sense. I mean, there's certainly.
I would think they wouldn't put psychiatrist down if it's not a psychiatrist, right?
You think they would? I'm sorry, Steve.
I think if the person is not a psychiatrist, they would do doctor of medicine. When psychiatrist is an option, or that code, I think they would make sure they don't confuse that, right? Bill someone who's not a psychiatrist as a psychiatrist.
So does this include billings? I guess I'm curious now, because there are a lot of non-psychiatric physicians who prescribe psychiatric medications, like pediatricians, like internal medicines, like OBGYNs. So were you looking at those billings too, Martin?
This would not include those. It only includes specifically behavioral health provider types. So if they're a pediatrician or general physician, it would not be included in this analysis.
Huh.
I would think there'd be a lot of family practice physicians that practice behavioral health, for example, and that's where you're seeing that.
A quick question: Are addiction medicine services also encapsulated here? This data.
If they're provided by the provider types that we had before, then yes, they would be included in this analysis. So if they are one of these provider types, then it would be included here.
Okay, thank you.
Hey, Martin, on slide 11, provider locations.
Sure.
I note that as a CMHC, one of our counties that we do have office and services in is not noted on the map. And the reason I'm bringing that up is it is Union County, and we are listed with one of the highest suicide rates. So I thought the CEO and I found that concerning, that was not identified that we are in that county. So it was just listed as non-CMHC services. So I guess the question is, can that be corrected? Where did that come from? How do we go about getting that pin on that dot, or dot on that pin?
Sure. So this is based on SAMHSA data. So if the location wasn't reported in SAMHSA, it would not be included there. And it was also 2022. And if there is a non-CMHC location nearby, it is possible the dots are overlapping, but I can take a look and make sure that we include that. This information will be going into an update of our report as well, so I can make sure that it is included for that if it hasn't been shown here properly.
Okay, thank you. Much appreciated.
So what happens to this data? I noticed that Aaron said that it would be posted on the TAC website, but what else do you do with it, Martin?
So this is going into our needs assessment report. And I am not sure on the details of what will be done with it from there. But I'm not sure where that will be posted or anything like that.
Yeah, it'll be part of our final report for the behavioral health needs assessment. I think the intent of these slides when they originally presented were just to summarize some of the pieces that we were seeing. So, we pulled some information out of the larger needs assessment for this group to look at. And then obviously there were some questions and comments, and we took those back, and this is addressing those, and this will help inform that final report. I don't know, Veronica, if you know, are there plans to publish that publicly, or have you gotten that far?
We have not.
Okay.
Yeah, thank you.
Mm-hmm.
And I think there was a question Liz Stearman asked about would it be updated, because there certainly have been some changes as we came out of COVID, for one thing, after fiscal year 2023. But at this point, this was a one-time study. Is that right, Brad?
Yes, that's our understanding as of now.
Okay.
That's not to say this couldn't inform, future studies, as far as mimicking some of the methodologies to do a new study in the future. But as of now, we were tasked with this one-time report.
Okay. Are there any other questions?
Yeah, I have one.
Yeah.
Where you have like a percent of the professional, right? That's slide, whether it's LCSW, whatever it is. Could we get a number of the total number of it? Yeah, and this one, the Medicaid utilization by provider type, the total number by region, because it may be a higher percent in one region, but it may be actually fewer people.
Yeah, that
Right.
is a challenge, because with the modifiers, we can see what provider type it was, but we can't necessarily see if it was a different different actual practitioner. We can only see the like billing provider level, and then below that we can tell what type of practitioner it was, but not distinguish them individually.
So you can't get an aggregate number for region 1.
No, I don't think that's possible.
I mean, I think the intent of that slide was to kind of show how each region is meeting their needs for the services based on the practitioner type, the rendering type.
So for example, Steve, this is Angela. For the peer supports, where we don't enroll them individually, they're billing through, a licensed practitioner. So we're getting the licensed practitioner MPI information with the modifier. So we don't know the number of peers. Does that make sense? We don't enroll them individually, so we're not getting that level of. So we can't say how many peers are providing services where.
Because my question really is about some regions have close to 1 million people or plus, and some have 100,000, 50,000. So the percent is good information, but it's necessarily a clean comparison based on it's the distribution, not a measure of how many total.
Right. Well, we thank Myers and Stauffer for their patience with us. We've been through several iterations of this, and that's been very, very helpful. And again, this will be posted, Aaron said, on the TAC website on DMS. So thank you very much.
Thank you.
Good work.
So who's doing an update on the 1915 I RISE?
I am.
Oh, good. I was hoping it was you, Ann.
Good afternoon, everyone. I am gonna give you a brief update on the regulations. We sailed through the R's, the AARS, and I can't for the life of me tell you what that stands for, so I apologize. No questions. They passed us right on. I spoke with Jonathan Scott, who handles the Medicaid regulations, and we should be assigned to a final committee this month. And fingers crossed, no issues there. We will be live. Our regs will be live July. Provider enrollment, as some of you know or may not know, we did go live on July 1st, and I have put in the chat our website. We've kind of had people start there, and so far as what I can tell you is we've had 34 individuals start that that certification process within the Adobe Learning Management System that is Medicaid's learning management system, and where all certification trainings are going to live, and everyone goes to one spot for that for 1959 RISE. Participant interest. We've had about 10 inquiries in our participant email box. We are looking at September to be able to start with referrals and verifying that initial eligibility and getting some assessments done. Of course, that all does hinge on, the provider interest in us getting providers onboarded and enrolled. And then I just wanted to mention that July 22nd, we'll be doing a hosted partnership with DMS and DBH-DID. Jody, Allen, and I will be putting on a webinar to go through sort of step by step for a provider, as well as the participants step by step, and go over the fee schedule and all the requirements, and also have a Q&A session. You can register. It is a registration for that webinar, and you can get to a link to register from our website, as I said, that I put in the chat. And that's where we are right now.
And that webinar on July 22nd, what time is that, Ann?
1 o'clock to 2:30.
Okay. And that's both for providers and potential
It's
participants?
really geared towards providers first.
Okay.
Because we're really focusing on, we've got to have the providers if we're going to be able to serve individuals. So we're going to target something out for, I don't want to say target. We're going to provide something out for potential participants, probably starting in August.
Okay.
Dr. Schuster.
Yeah, that sounds.
Yeah.
I think there's two levels of
yeah, but it's exciting.
Yeah.
I've talked to a lot of people, and yesterday, let's see, I get my days confused. Tuesday, talked to the long-term care ombudsman program about they're interested in their individuals that live in personal care homes. So
Yeah. When you have time, can you shoot me the link to that registration?
I will.
We can get that out. Thank you very much.
Liz Stearman, you got a question?
Liz, you have a question?
I did, just really quickly. So for participants that do get enrolled in the RISE program, I know that that those additional services that are part of that program are covered through that RISE waiver. Are everything else for those folks? So are they going to be moved into fee for service for all other coverage and not MCOs? Is that what happens? Okay.
Yes, they would move out. They're moving out of MCOs into the fee for service.
Okay,
correct.
Thank you.
Okay, that's a good clarification. Thank you for asking that, Liz, because I hadn't thought that through. Yeah, thank you. Any other questions of Ann? Okay, very exciting, Ann.
It is. I'm excited. If you can't tell.
Webinar on the 22nd, I can tell you were excited.
I am. I'm very excited.
And how about a status update on the reentry waiver?
Good afternoon. Again, Angela Sparrow will provide a little update on where we are there. We again are still targeting a 10/1 go live date for the reentry implementation with Department for Corrections and Department for Juvenile Justice. Again, we did receive some feedback from CMS on our implementation plan that we submitted last fall. So that was good. We said early on in the process, it could be months, and it typically is. So it really wasn't anything, had mentioned, earlier, no showstoppers there, just more some comments, call outs to the states and some considerations. But nothing, again, that requires any major design changes to the program, anything like that. So we are planning on submitting our feedback to them and any revisions by the end of next week. Again, it is not going to prohibit us from moving forward with a 10-1 implementation, but it was good to get some of that feedback. Once we get that finalized, again, we can share that plan and post that. But again, typically we don't do that until we get the final approval from CMS. So again, it's not atypical that it takes months to do that and get through that process. But again, we were pleased that we do not need to, doesn't appear to make any major changes to the program design. So that was good. We had mentioned again our monitoring. So we had submitted our monitoring protocol to CMS last fall as well. We have not received any feedback from them on that still to date. We've had some communication and direction from CMS that they're changing or changing up monitoring for all 1115 demonstrations. And so we're anticipating that they will give full guidance to states and more prescribed metrics around reentry demonstrations to all states so that it's more streamlined reporting. We anticipate that will be released in fall. So we're moving forward as of right now with what we've proposed. We might have to make some changes when we get that guidance in the fall. But again, that will be, we anticipate to be good guidance so that we are, all states again are in more of alignment and understanding expectations and monitoring. So that's something we're just trying to consider as we roll out. We may roll out and need to make some changes to our monitoring plans and protocols. Certainly, again, continue to meet, work with the Justice Partners, DOC and DJJ, developing, again, workflows, our policies, finalizing policies, standing up those standard operations, protocols, again, discussing DOC and DJJ have both submitted their enrollment applications for that new provider type to the department, and those are under review. So again, working to try to expedite those, ensure that they're in place so that DOC and DJJ can begin the credentialing process with MCOs. So working with the MCOs around that process, expectations again, to have those things in place and contracts for 10-1 go live. Pharmacy, again, still working through those work groups. We, again, part of those workflows, process development with DOC and DJJ around trying to be proactive in terms of aligning PDLs between their correctional PDLs and the Medicaid PDL. So if there needs to be potentially a change to a preferred medication, if it's appropriate, that those are occurring prior to that release date. If there requires a prior authorization, that we again are completing those process before the actual release. So working through those process, making those system changes. And again, we will be enrolling their contracted provider as well, pharmacy provider. They DOC and DJJ continue to work with their vendors. Again, they have system changes to support implementation, identification. So all of that work is still underway. We did complete sessions on the DMS side and with our justice partners on systems. Again, we've talked about comprehensive system changes across many systems. And so we finalized those requirements and that development is underway. Finalizing rates again for the MAT service, the medication assisted treatment that DOC and DJJ would be billing for, ensuring again that there's access to those services across all facilities. So again, what are those policies, procedures? Continued effort with MCOs, supportive at the table again, eager to work and be able to provide services to this population. We again, working with them through system changes, understanding those system changes, eligibility. So lots of work occurring and continue to occur. And again, ensuring that hopefully we continue to stay on track. But 10-1 is itching up on us for sure. And I know we're all ready to get to that line and hopefully again be able to start providing these pre-release services and especially that case management follow-up.
Yeah, that sounds like you all have been very busy, Angela, and we've all been waiting with bated breath, as they say, on getting this launched. So thank you for that. Any questions for Angela on the reentry? I know you had a meeting this morning, Steve. Reminder that reentry TAC meets the same day as the BH TAC, and they meet at 9 in the morning, and all are invited to attend. Thank you. Just a quick note on the MOAB, the Medicaid Oversight and Advisory Board had its first meeting on June 25th. In a nutshell, there's 25 members of the MOAB. The 10 voting members are all legislators. Senator Julie Rocky Adams and Representative Ken Fleming as the co-chairs. The chairs of Health Services Committees, Senator Meredith and Representative Moser. The chairs of the Family and Children's Committees, Senator Carroll and Representative Heverin. 2 other legislators, Senator Craig Richardson and Representative Wade Williams. And then there are 2 Democratic legislators, Senator Berg and Representative Marzian. And then there are actually 4 more legislators, although they are non-voting. The chairs of the A&R committees, Senator McDaniel and Representative Petrie, plus Senator Douglas and Representative Adam Bowling. And then there are a number of citizens, the EMS Commissioner, Lisa Lee, the state's Chief Medical Officer, Dr. Stephen Stack, the State Auditor, Allison Ball, State Budget Director, John Hicks, 4 citizens with Medicaid experience, Holly Harris from ARH Hospital and Joe Petrie, who's the dentist from Corbin, were appointed by President Stivers, and Vicki Yates Glisson, who's a health attorney, and Steve Shannon were appointed by Speaker Bowling. The head of the Center of Excellence in Rural Health, Beth Bowling, representative of the MCO organization, Tom Stevens, and then yours truly as chair of the Medicaid Advisory Council. So I would direct you to look at House Bill 695 because everything you want to know about what the MOAB tasks are. I mean, basically it's to really insert the legislature into an oversight and advisory board, but actually a permission granting board for waivers and changes in waivers, state plan amendments. The board will review, analyze, study, evaluate, provide legislative oversight, and make recommendations. So I think there are meetings that you will want to monitor. They are meeting on pretty much the last Wednesday of the month till through November. So July 30th, August 27th, September 24th, October 22nd, and November 19th to avoid Thanksgiving. And those meetings, like all committee meetings, are also available either on KET or on the LRC YouTube channel. They did announce at the first meeting that there would be an opportunity for public comment. So they will set aside the last 15 minutes of every meeting for as many people as can speak with a limit of 3 minutes. And it's going to operate the same way as testifying or making a public comment at any meeting. So sign up sheet in the back. So if you want to speak on any of the issues around Medicaid and the MOAB, then I would suggest that you get there early to sign up. And if you have any questions about it, you can email me directly with those. Veronica, are you going to talk about the Beneficiary Advisory Council and the changes to the MAC?
Yes, I'm happy to. Thank you for the opportunity. July 9th, the federal rule went into effect that required us to make those changes to the Medicaid Advisory Council and committee, and create the new Beneficiary Advisory Council. I know people might be tired of hearing about it, but we wanted to make sure folks were aware of what was happening. And just a very quick reminder, what we did in Kentucky to comply with the federal requirements was to maintain the membership that was part of the original Advisory Council for Medical Assistance that's in state statute. We added in additional representation that is required by the federal rule, and that has become our new Medicaid Advisory Committee. We did make appointments on Tuesday, and everybody should have received their appointments. What we are doing now is working with the new BAC, Beneficiary Advisory Council members. We're contacting them. They have, according to the federal rule, they're allowed to not have their name posted. So we are contacting those new appointees and asking them that question if they feel comfortable with having their name posted. As soon as we complete those calls, and we should have that done by the end of the week, we will then post the new list, and we'll send that out to the old MAC email address, to all the new members and to the TAC, so they're aware. And then we'll also send out our general email distribution list about the new information that's been posted. We are making some additional updates to our website just to keep it current with what's happening. The next step for both the new MAC and the BAC is to do an orientation for the new members to help walk them through, because we do have a lot of new members, is to walk them through what that means and what that looks like and what that engagement looks like. We're also going to be asking what kind of support or help that somebody might need to participate in the council and committee. So we're going to be working through and identifying those needs so that we can make sure that we have, we're able to support their active participation. We'll also be, during the next month, working on setting a schedule that's convenient for the new membership. And we hope to get those meetings out to the public so they're aware. Just a reminder, we are required by the federal rule that the BAC has to meet before the MAC. So this is, going to take a little bit of scheduling challenges to make sure that we're following those rules. And I do want to make sure that we are listening to the BAC members and supporting them and their needs and, what their requirements may need to be able to participate. So that's where we are right now. And definitely, I think by your next meeting, have a lot more information to share, including hopefully meeting dates and how we're moving forward.
All right, I know you all have been busy going through the applications and so forth, and I knew that the notifications had gone out to the BAC members. Anybody have any questions for Veronica?
Summer, Patrick.
I'm sorry. Oh, okay, wasn't for us. All right, thank you very much, Veronica.
You're welcome.
We always have this on here. Any follow-up on audits conducted by the MCOs? Any issues? Maybe
We're
we're,
hoping PAs reduce audits.
what?
We're hoping PAs reduce
PAs
audits.
reduce audits, yes, we are hoping for that. And we spent a lot of time on the PAs, so if there aren't any burning issues, we'll go on. Not sure who's got the current 1915C
I'm
waiting
sorry.
list. Sorry,
Could I bump in? I'm sorry. Jennifer had asked me to provide a little update on our TCMs out for number 11 there, and I was on mute. I didn't realize. I apologize.
Oh,
I don't know
all
how
right.
this many years into into doing this, I still was on mute, but I was. So I apologize.
All right.
But I did just want to give a quick update that we in February, we did make the change to the MCO requirements that instead of looking at 50 TCM members when they do a look back, they would do 30. And we have seen over, this has been years of a process of us tweaking and making this process as efficient and not burdensome as possible. And so we have seen a lot of improvement. I know when we're doing our audits, we are seeing a lot more no findings than we used to find. And probably our biggest citations that we runs into where the credentialing with the beaded system not being updated in their TRIS system. And I know I heard them talking about that, and they've been doing a lot of updates to the TRIS system that I think will be improving that. And then probably the other biggest thing that we see are documentation issues with things not being signed according to the regulation within the 72 hours or not dated, so we don't know when it was signed, that sort of thing. But we haven't really had any other changes right now with the TCM audit process. I just wanted to give a quick update. So,
all right. So that change was made in February to go from 50 members audited to 30.
yes, it was effective February 21st.
Okay, wonderful.
Mhm.
All right, that's very helpful. Thank you very much.
Thank you.
Okay. How about current 1915C waiting list numbers?
Yes, hi, Dr. Schuster. This is Carmen with Long-Term Services and Supports with Medicaid. I've got those waiting list numbers. So ABI Acute and ABI Long-Term Care, neither one have waiting lists at this time. Home and community-based waiver, total on the waiting list is 5,001. Model 2 also has no one on that waiting list. Michelle P is 9,588. And SCL is 3,654. I did want to go ahead and mention that the slot allocation plan that was approved, we did have some additional slots that opened up starting July 1st. ABI long-term care has 25 additional slots. Those are immediately available. HCB has 500. We're going to be rolling those out over the next 3 months. Michelle P. Waiver has 500 slots as well that have opened up. Those are going to be rolled out over the next 6 months. And then SCL has 250 new slots, and those are going to come roll out over the next 3 months.
Well, that's good news.
Yes, ma'am.
Carmen, I apologize. What was the last number you just gave?
SCL, the new slots beginning fiscal year 26 is 250.
Thank you. I wasn't typing
Yep.
fast enough.
Thanks, Erin.
So the new slots in ABI were just for the long term, is that right? 25?
Yes, ma'am. Mm-hmm.
For acute, okay. And the numbers on the waiting list, are those duplicated or unduplicated? I always have to ask that.
They are going to be duplicated, so there are multiple people that are on more than one waiting list.
Okay.
Mm-hmm.
All right, thank you very much.
And then I also see the update on waiver, ABI waiver access to therapy services. So anyone who is on either of those waivers who's currently accessing services through the waiver, they can continue to do so. But for new participants or someone who's just now accessing therapy services, those are being redirected to state plan.
Okay, so that hasn't changed. I mean, that's been the response, I think, the last 3 or 4 meetings that we've had.
Yes, ma'am, that's true. We don't anticipate anything changing with that until we can get changes to the KARs through. But we're down to the ABI waivers and Michelle P that have therapies left in the waiver. And again, we are trying to align those with the others and redirect everyone to state plan services.
Okay, thank you very much.
You're welcome.
Bart, you and Mandy had some concerns about delays in credentialing new providers. Can you tell us about that?
Sure. Thank you, Dr. Schuster. And this is really just a request or just something to flag with the folks at Medicaid to see if there's some assistance. This really, I think, is broader than just this group, but it came out of our ABA providers or licensed behavior analyst group. Just delays in getting credentialing from Medicaid, because that's the first step when you have a new staff member or generally a newly licensed staff member. Lots of times when they're moving folks up, progressing through their education and newly licensed, first they have to get credentialed through Medicaid before they can go to the MCOs to get the credentialing there and get them on before they can start billing for services. And so we dug into it a bit, and the regulation actually allows 90 days. And so we don't have too many instances of longer than 90 days, but just wanted to point out that that's still a long period of time once you've got somebody licensed and ready to provide services, and you've got them on staff and ready. What are you going to do in the meantime, especially with a lot of these organizations that have individuals on waiting list that desperately need these services. So we just told the group that we would bring it up here to see if there is a way to expedite. I didn't realize that it had, frankly, it used to be where you could apply with an MCO and get credentialed through Medicaid at one time, but now it's gone back, and I don't know when this changed. Back in the late teens, I guess, pre-pandemic, when we were really trying to, the new implementation of BHSOs, multi-specialty groups, expansion, et cetera, we were really trying to ramp up and get as many folks credentialed as possible. Medicaid was really trying to expedite that. So it's just really a request to see if there's a way to shorten that time frame down, because it just delays access to services. I mean, I don't think Medicaid's operating outside the regulation, but it's just 90 days, 3 months tends to be a long time. When you've got somebody that's licensed and ready to see clients,
and you can't bill for them,
and you can't bill for them until they're getting credentialed.
Right.
So, yeah.
This is Chris Turner with CMS to speak a little bit to the credentialing process. And
Sure.
We were just kind of wanting to gather a little bit more information on what type of delays the providers were experiencing. And, just on our internal, just kind of looking at things, it looks like we have been credentialing behavioral health providers well below the 90 days. So, but if there's a particular provider that's experiencing some issues or, an extended wait or something like that, they can always reach out to our provider enrollment if they're needing assistance with something to kind of speed that along or something along those lines. Were there any other specific examples that you had where somebody was having like very significant delays with credentialing?
We requested some of that, and I'll get that to you. I'll get you some more details. But
okay, please.
Like I said, when they were talking about it, it was a few months, and I thought, oh, well, it's supposed to be 40. And like I said, in my head, I thought it was supposed to be 45 days, but at some point that changed to 90. There was a shorter time period for a period of time for behavioral health than it was for other providers. I don't know, Steve and Sheila, if y'all remember that, but maybe I just dreamed it. But anyway, so.
Maybe that was
Maybe-
wishful thinking on your part, Bart.
But anyway, but Chris, yeah, if you don't mind popping your email in the chat and we'll reach out to you and send you some more info.
Okay, certainly I can do
All
that.
right. Thank you very much, Chris. We appreciate that.
Thank you.
And obviously this is, maybe not a huge issue, but it's a huge issue for the provider and for the agency when it gets pretty close to that 90 days. Because as you say, you've got them on the payroll, they're licensed, they're ready to go, and you can't bill for them yet. So thank you for bringing that up, Bart.
If Dr. Schuster, you don't mind,
Yeah.
so we, believe it or not, we track this every month. We
Oh.
track the average number of days that it
Right.
takes for provider enrollment. And we are generally always beating 30, shorter than 30 days. So if there's a provider that's caught up in a lengthier process, it's probably us trying to go back and forth to get the necessary information. Because once we launch the portal, we try that streamline things so fast, and we can generally, if all the information's in there, like 3 days, we could get somebody enrolled. So just be mindful of that. I think one of our biggest challenges is that, it gets worked in the order received. And our average processing time, when I'm looking here, is around like 25 days. So something's not right if somebody's, and that's an average. So we've got, folks longer than that, folks shorter than that. Our biggest challenge is just making sure all the information is in and accurate when it's submitted. So, and we do a lot of back and forth trying to request information. And we try to promise, once you send that request for additional information, then they kind of get back into the queue until you can get back to it. So that's part of our challenge.
Thank you. And Veronica, there's a question in the chat. Did the regulation change for PT 66 for the behavioral health multi-specialty groups in April of 2025 that requires this provider type to have 2 providers on the enrollment in order to credential?
I don't know, Chris, or Angela, if she's still on. I don't know if they're able to help with that question. We generally in the past have only required 1 provider to be able to create the group. But I don't know, Chris, if you have more information on that.
I know that is something we had been discussing with Angela, and I'm not for sure if she's still on the call to go over that.
Yeah, the regulation language has not changed. The language has been there. I don't have it in front of me, so we can pull it and follow up exactly what it does state, but it has always stated that it is more than 1 practitioner. It was not a regulatory change. That language has been there.
So I'm the one who wrote the question. My name is Ivy Livinggood. I do credentialing for various different providers and group practices, and I have historically I've submitted enrollments for groups and only included 1 provider for this provider type, and they've always been approved. And I was told recently an application got rejected, and I was told it was because there's 2 providers that are required to be on the enrollment.
Okay, thank you, Ivy. We'll take that back and just double check.
Okay, this was a change. They said it was something that changed in April 2025.
Ivy, if you'd like to drop your email in the chat, I can share that to make sure someone's in contact with you.
Thank you.
Yeah.
And
We
thank
aim
you
to
for
be helpful here. Thank you for bringing that up. I'm going to skip right now the recommendations. How about, and this was, I don't know if Hannah Brosnan from Mental Health America is on, but she was in DC and talked to some staff members in Congressman Massey's office. And one of them had a specific question around behavioral health and wanted to know if there were any particular issues, barriers, problems with behavioral health providers and telehealth. And so I put that on there to see if we could get any feedback.
Well, the only thing, this is Nina, we were
Nina.
waiting on the final clarification to come from DMS as to whether or not BH services, IOP, PHP could be provided via telehealth.
Right, and that's a DMS decision that
Yes.
you're waiting on, right?
Well, we were waiting, communication way back when, maybe last January or something, was that CMS did not have an issue with it, but we were still waiting on a provider notice. And so, and when we've asked, it's, DMS has said it's in development, but we haven't seen it yet. So I don't know if anybody from DMS has an update.
And that's behavioral health in your partial hospitalization programs?
Yes, and IOP, PHP and IOP.
IOP. Okay.
Tele for Medicaid patients.
Yeah.
And it was an issue for hospitals and also other providers throughout the state who do IOP.
I don't have an update, but certainly we'll take it back so that we
Thank
can
you.
provide one. Thank you.
Okay. Anything else that anybody wants to bring up about telehealth?
Well, I would just say, I would add that in Kentucky, it's a really important alternative for providers because we have so many problems with transportation to providers. And so this really does improve access and for folks who might have those challenges and not be able to get to someone in person.
Yeah, I think that's absolutely the case. Even
Yeah,
though we don't have internet everywhere either, but
Yeah, exactly.
Well,
Hey,
we do.
Justin.
Yeah, I would just add that, I mean, just as far as feedback and telehealth, I think Kentucky's done a really good job of post-pandemic, putting in permanent a lot of the flexibilities and the utilization to be able to utilize telehealth, both in statute and regulations. So, I mean, if he's just generally looking for, I think that it's probably pretty positive.
Yeah. I mean,
It worked really well. We were just waiting, when the public health emergency ended, we were waiting for clarification. And I see Justin on. I don't know if you have an update.
Yeah.
Hi, so this is Justin Derringer with the Vision of Healthcare Policy. We had that, as you all know, we had a change for telehealth in partial hospitalization, and then
did you freeze, Justin?
I think he
I
froze.
think he is frozen. Yeah. Nina, maybe you and Justin can have a offline discussion to finish this up if we.
Sure.
Yeah, thank you.
And I know that Bart, a lot of you represent a lot of folks who also needed clarification on the IOP.
Yeah. Has there been any problem with the rates? Are the rates the same as in person?
Well, we haven't, in hospitals, we haven't been doing it because we've been waiting for clarification.
Waiting for clarification. Okay.
Yeah, and also whether or not the billing would be the same as during the pandemic and so on.
Okay. All right. If anybody thinks of something and they want to add it, shoot me an email to kyadvocacy@gmail.com, please. Nina, did you have anything else?
No, ma'am.
Oh, okay. Thank you. Under new business is Liz McCune on. There you are with your hand up.
Right.
Your new business item, Liz.
All right. I wanted to bring up
and ask that the TAC consider requesting regular tracking and reporting regarding updates to the peer support specialist roles and how they've been impacted since the changes to House Bill 505 and the updates to the certification process being planned now by the Department of Behavioral Health, Developmental and Intellectual Disabilities. Here at 7 counties, we specifically are concerned about the billing uncertainty for peers when they will have the status of temporary registered alcohol and drug peer support specialists, and whether during that period of time they would be able to bill. We're also concerned that the application process is somewhat cumbersome and challenging. They will be filling out the same forms that someone who is an LCADC or a CADC completes in order to obtain the designation from the Alcohol and Drug Counseling Board. In addition, there's other barriers such as the cost of the training requirements, the supervisory challenges that could come up. We have been tracking all of these and have a long list and would be happy to provide that with regard to just concerns for, we very much value having this experience and service to be able to provide for our clients, but recognize at the same time too that the unique experience they bring is that they have lived experience. And so creating additional barriers could make this very difficult for the individuals who provide this service, and just want to make sure that we're tracking it closely. And there's just a lot of moving things at once, and these roles are not highly compensated, and to add a lot of additional expense and barriers to the process could put those roles at risk.
And a huge amount of work has to be done by the board, right? Come January.
Yes, we met with,
that's that whole processing piece,
yes, we met with
and
Karen Haskell, who's the chair of the Alcohol and Drug Counseling Board, and just went over some of the concerns. And I understand that, this was a bill that was passed and we're all navigating and trying to figure it out to do our best at implementing what's been asked of us. But it is very challenging, and our individuals who are in those roles are very concerned. And we just want to try to clarify as soon as we can and help them navigate the process, and thought that it might be helpful to hear regular updates through this forum.
I think that I have heard, Liz, and I appreciate your bringing it up because there have been lots of concerns circulating. I don't know, Tara Hyde, are you still on? Because I know that Tara and I talked, and she had some concerns.
Yeah, I'm still here.
Yeah, because you had talked, we had talked some time ago, Tara, and you had been concerned that everybody was getting put under an SUD kind of rubric where there were a lot of peer support specialists that were not necessarily SUD, as I recall.
Well, yeah, well, there's a lot of limitations that well, there's a lot of restrictions that will go into place just because it will require certain criteria for those peer support specialists, which, I mean, the idea, like I again, right, like someone just pointed out, the idea, like I understand it because, you want to be accountable and, have standards and be able to track and monitor and professionalize, but also like, it also is creating a lot of barriers and limitations for where peers can be utilized and where it can be a billable practice in community settings outside of clinical settings. So that's, some of the disconnect and concern that my community, a lot of folks that I worked with have, and then also like the disconnect between like so many different types of and trainings that are available and the certifications and whether they apply or don't apply and how that works, and just a lot of those sort of challenges as we kind of move forward and how that's going to roll out. So there's just a lot of different questions that I think are kind of left unanswered here.
Yeah, I think that's the case. And I know, Steve, you've talked about the, just the expense
Yeah,
of the licensure or the
the
certification
process, I
process.
think like almost
then-
$300.
Yeah, and I think Liz said that some of the required training has a cost to it as well.
Yeah.
Is that right, Liz? Yeah.
And it's rather lengthy. I mean, some of the requirements as proposed are more so than some of our fully licensed independent people. So just trying to advocate and look out for individuals in those roles.
I'm very interested in if the BH-TAC is a good place to keep an eye on this and have, you know, an update. Liz, if you wouldn't mind sharing your list of maybe some of the things that we might look to gather some information about. This may be one of those things that after we get some information, there's some feedback that we might give to Representative Moser, who was the author of that or the sponsor of that bill, with, I think, the best intentions, but maybe having it work, because we all value peer support specialists and their lived experience. But as you pointed out, Liz, if the training and the requirements create conflict even with their lived experience, that's not real helpful. And so I know you've pointed that out as well, Tara. So why don't you share that list with me if you would, Liz, and then we can I can circulate with the voting members of the TAC and kind of start there and see if we can build out something that we could have on a regular basis. It may be helpful also to get some input from DBH DID, because they are still credentialing peer support specialists, right?
I have a little bit of information I can share that
Okay.
Phyllis Millspaw is kind of leading the charge around peer support training, and she's actually working on getting a meeting with the Drug and Alcohol Board, and as well as I'm pretty sure it's the behavioral health specialist within DMS too, for everyone to talk and discuss this. So maybe that is an agenda item for your next meeting. The next behavioral health TAC, and I will bring this back to the Department of Behavioral Health as well. Let them know that you're asking about that, and it would be helpful and very, very beneficial to have those questions and concerns, Liz, and I'll pass them on.
Yeah, we've just been trying to keep a list of when we've talked with different people, so that because we're just trying to figure it all out, and I know everyone else is too. But I'd be happy to share what we have at this point.
Be great.
Yeah.
Yeah, I think that would be helpful, Anne. And if you would communicate to Phyllis and certainly to Commissioner Marks that we want them included in this discussion, because we're very aware that they play an important role with the peer support specialists as well.
It is a lot to navigate through because, what if they're both? What if they both have, they can be a peer support for just a mental health diagnosis as well as a SUD? Does that mean they got to have both?
Well, and I think that's one of the questions. And then if they have to have
Answer
both,
is yes.
you're in
that's what I've been saying, Steve.
You're in the supervisory concern.
Yeah.
Right.
Yeah. So and the only reason I knew that is because Phyllis asked me to participate in on that discussion. So that's how I had that little bit of information to share.
Yeah.
I think they would have to have both. I mean, that's like we actually have a schizophrenia alliance group that we do over at Eastern State Hospital, and I mean, if you don't have schizophrenia, I don't know how you could feel like you could teach that intelligently. You know what I'm saying?
Yes, correct.
I don't have SUD. I don't feel like I could step in and lead a SUD group intelligently. You know what I'm saying? I mean, it seems like it's kind of a no-brainer there, but I don't know.
It is. It will. It as it stands, it is both. You're right.
Yeah. All right. So we'll put that on the September meeting and kind of work off of a checklist or something that we can gather information around. Thank you very much, Liz.
Dr. Schuster, this is
yeah.
Erin. I got a message from Justin. He apologizes. He lost power at home. He was going to
Oh.
try to log on his phone, but he does apologize for dropping
All right,
suddenly.
well, thank you. We might just,
There he
tell.
is.
Hey, I'm
Oh.
back on. I apologize. My power went out, so I was gonna let you know that that is still pending decision, but I'm hopeful that we should have hear something by next week. So that's as you all know, we try to do a great job with telehealth, and we have all the most of our codes that can be done remotely, or we allow to be done remotely. But that one particular issue was a CMS issue, and so hopefully we'll have clarification and a decision sometime by the end of next week. That's our goal. I know it's been out there for a long time, but that's where we're at with that. That's the update on that one.
Great.
Thank you.
Yeah, I know that Nina's happy to hear that feedback. Thank you, Justin.
Thanks, Justin.
Thanks for getting back on. Let's see, where are we? Oh, formulary issues. There was a little bit of a kerfuffle because we had heard from a national group that the P&T committee, the Pharmacy and Therapeutics Committee of Medicaid, was going to be making some changes in the antipsychotic medication class. And so Dr. Ali was very kind and clarified that for me. And I also talked to someone over at Med Impact. And this is just a annual review. There's a long list. If you look at the agenda for the P&T committee, which is July 15th, there's a long list of drug classes that are just on there for review, but where no changes are being recommended. So none of the psychiatric medications, depression or antipsychotic medications, have any changes being recommended. So we're very relieved to hear that.
Hi, Dr.
Yes.
Hi, Dr. Schuster. My name is Raina Van Gelder. I'm here representing the pharmacy department. And if you had any additional questions, I'm happy to entertain those from you or the group.
Thank you. I appreciate that. And I know that Dr. Ali said that someone would be on, because my thought was that if we had something going on at P&T, I usually rely on Val to tell me if she's hearing anything on formulary issues. Any problems, Val, that you're aware of?
Not that I've heard, no. I was curious about the Abilify LAI that is a 6-month LAI. Is there a problem with that one? I can't remember what the name of it is.
I don't know.
I can't remember that.
You know, Raina, what the name of that one is?
I'm sorry. Is it the Aristata perhaps? Or
Yes. Assume there's no trouble with that, or you would have said something about it. I haven't heard of very many people that are taking it yet. So
I guess that raises the question, though, and I didn't look, Raina, are all of the LAIs on the preferred drug list?
injectables are on the PDL. We do have quite a selection of different chemical entities, anything from aripiprazole to different formulations of risperidone and olanzapine that are in our preferred class. We do have a couple in our non-preferred class as well.
Good. So there probably is available. They should be available now, is what I'm hearing there. So any other questions? And thank you for being on, Raina. We appreciate that.
No problem. And I just did want to mention there's typically a diagnosis check associated with the antipsychotics, whether it's the oral or the injectable.
Right. Okay, thank you. Let's see. I think we have covered everything. Erin, you had sent a notice out that there's a Medicaid provider directory that's now online.
Yes, ma'am.
Can you put that link in the chat?
Absolutely. Give me just a second.
Okay. So there's, and people may want to check and make sure that if they're a provider that they're in there. It went live on June 26th. And providers can begin updating their office information in MPPA. Thank you, Aaron. There is not going to be a July MAC meeting because of the changes that are going on with the BAC and the MAC. And we're hoping that there will be a meeting in September. Right now, it's tentatively set for September 25th, 9:30 to 12:30. And we are hoping that that will fit with the new BAC in their meeting and so forth. You heard from Veronica that it's kind of a much more involved process now to kind of coordinate these two groups so that the BAC, the Beneficiaries Advisory Council, meets sometime before the MAC meets each time. And I think that's all I have. I think I covered all of my little notes here. Does anybody else have anything else they want to ask or? All right, I appreciate you all staying on with us here. I knew it was going to be a long agenda. We'll try to do a little bit better next time. But thank you all, and thank you, Aaron, for keeping us on track as best as possible.
You're very welcome. And I just dropped a very lengthy message in the chat with all the different links.
Great. Thank you very much. And we will meet again on September 11th at this usual time. So I wish you all a happy rest of your summer and stay safe, stay cool if you can. And we'll see you in a couple of months. Thank you.
Thank you, everybody. Have a great evening.
Thanks. Bye-bye.